where your child are, but that should really improve it and helps you in the yourself. Just like the other day when we are at Moi Forces, we discussed like the challenges in children. Now today we're talking about adolescents. Now for adolescents, we should really take in and engage in parental empowerment, like putting goals with your child together so that you can identify their talents and abilities. And another problem is health concern. Educate the youth about the health concerns, like the health concern of HIV. What can we do to prevent HIV? Or what are the causes of HIV and how can we prevent it? That's the thing we should sit down and talk to our children. And another thing is drug and substance abuse. Please, parents, I don't know if you're people, you're alcoholic people, but Almighty God tells me that you guys are not people who take alcohol, right? I want to be sure because alcohol is not a very good way to relieve stress. So parents do not take alcohol because what your child sees is what they do. So they practice it later and later leads to addiction. So yes, thank you, and I hope you enjoyed our skit about adolescence, and happy adolescence today. Thank you.
Like my friend Bright has said, the other day we were at Moi Forces and we were talking about how we can make education work for children in Nairobi. So children in Nairobi, although education is a very serious matter to be discussed, education cannot be achieved successfully if the health of the child is deteriorating. That's the one. And if a child feels stress or peer pressure, they will not focus in classes. They won't even try to learn. They'll be failing and they'll be like, it's all right, blah, blah, blah. And we feel like if the children were their mental health, they would be able to understand why they should really seek care of counseling and help them manage their stress.
Yeah, thank you for your time and appreciation. I hope you take in our points that you made help us. And another thing is in Kenya, there are approximately 13 million adolescents in Kenya. Can you imagine that number? Can you really do something like put all us adolescents together and talk about these issues? If that is possible, right? And about 1.2 billion, that's a quite number in the world. That's the number of adolescents in the world. So we can imagine how many we are. You know, we are the adolescents, like I don't quite remember Madam's name, but he told that you guys are going to get what, and us we are going to replace your sports. So you should educate us on what you're going to prepare, right? Yes. So thank you, and have a nice day.
Have a good day.
I think clap for this, our good adolescent. That was a serious performance. Hizo vitu zote tunaona kwa kichwa. Those data, some of us we are struggling to make difference. The meeting was to end now. We would have ended it by that presentation because we are already done exemplary work. To the teachers, adolescents, umefanya kazi nzuri, si ndio? How many clap for them again? That was a wonderful performance. After that adolescent kind of presentation, we do a small presentation which is for record purposes. Because such a serious meeting, you might not just end by that. So we'll have a presentation by the director and then by Dr. Juliet that will summarize all serious presentations of the day. After that, we shall go for break. And then we'll come back for another round of adolescent issues. Is that right? So welcome, Dr. Shiloya. Okay. Yes, she's still doing some one or two things. Let me contact.
It's not connected. Wait, some.
As Dr. Makeba is preparing, do we have those who arrived late after we had done introductions? We'll give you time to introduce yourself.
Anyone like to introduce yourself? Anyone? Yes. Please go you. Hello. Your name, organization, and then why you're here.
Thank you very much. My name is Dr. Maria Amalebi. I'm here on behalf of Kenya Health Corporation.
But I'm quite sure you'll not be able to help this. Ina hizo
Hi everyone. Good morning. I'm sorry I was late.
niko na jam,
My
niko
name
na
is
jam.
Thomas Nakamani. I am the ESPP for Prevention. I also sit on the board of Kenya Education Fund, and I'm here because I'm interested in the work that we can do and partner with different communities based on adolescence. Thank you.
Good morning, everyone. I'm very Patricia. I'm a pediatrician working in Bubu Sub-County in Kiambu County. We are to learn more how to help the adolescents get
Actually,
better.
I thought company niko explaining task. Oh, so
Hello, everyone. My name is Mercy Chepto. I'm a radiologist working at the National Disease Surveillance and Response at the Ministry of Health. I'm also here as a youth to also learn and probably participate in the discussions.
Good morning, everyone. My name is Beth Kimwana. I'm the Executive Director for Population Council Kenya. We are a research organization and we do a lot of work on adolescents. And we're here to just listen and learn. Thank you.
Good morning, everyone. My name is Julia Taylor from Women in Justice Centers. I'm a youth advocate of this organization.
Good morning, everyone. My name is Charlotte Akini from Women in Justice Centers. I'm an advocate.
Morning, everyone. My name is Augustine Moore. I'm a final year student at Kenyatta University and also a member of the Edge community and a proud CSB member. Thank you.
Good morning, everyone. My name is Mercy Nzuki, LVCT Health. I'm really looking forward to seeing how we can garner efforts to ensure that at least we support adolescent and young people in Kenya.
Thank you very much. We're still expecting more people to come. Person was handling the music. Is there some? Is that ready? Yes. Apologies for. Okay. technological issues and shadow crime. So welcome Dr. Makeba. Karibu sana.
We are next to one. It's all about them. So thank you so much, and thank you for being there. We have an opportunity to be here because of the elections continue to speak about advocate their health and well-being. So my role this morning is just to give a bit of context of Africa, just to understand where the adolescents are, what is the status of adolescents' health, some of the statistics, not everything, but some of the statistics of Africa, because we belong to the continent, and we are linked to conventions. What we see is that the trend is that we have an increase in the adolescent population. And this graph, as well as the table, just shows you that there's been a trajectory, an upward trajectory, the population of adolescents in the continent. So on the right, you have the graph showing that currently we have 200, give or take, 255 million adolescents in the African region. You remember one of our young ones mentioned, I think he said 13, and Dr. Juliet will confirm that, but they're aware of how many they are. And we're saying that this mirrors what we're seeing in the rest of the African region. We have almost 50% of our population currently being adolescent. And you're aware adolescent starts from the age of 10. So we have early adolescent, middle adolescent, and then late adolescent. So we're talking about that range, from 10 to 19. And that is the age we're talking about adolescent. And each of those groups have specific needs. But the take-home message is you are really the star of the African continent. 25% almost of our current population in Africa is adolescent. So this is the time, this is we must be able to focus and to direct our policies, our strategies to cater for the needs, and it needs to be a multi-sectorial approach. Because again, as they spoke to us this morning, their needs were diverse. They related to mental health, related to sanitation, to aspects related to various illnesses, but also aspects that we could see related to poverty that could affect their health and well-being. With the ratio between male and female, it's more or less the same in Africa. We don't see the wide variation demographically. And this again is important in terms of programming, because we saw what we were told, that as a male adolescent, what are you thinking about? And what are your needs? As a female adolescent, issues around menstrual hygiene. So in your programming, to understand what is the proportion of our male and female in our continent also helps us to program. So by and large, it's almost one-to-one, and this mirrors I think what we also have in Kenya. So for Africa, we divide our countries into high, low, medium income, and then upper medium income. So Kenya is in the lower middle income category, and in the high income category, we have countries like Seychelles, and then in the low income, Congo, Ethiopia, a lot of the Central African countries. And then for the low and middle income, Nigeria, Kenya is in this category. So we note that in the low income, that's where you have a higher proportion of adolescent population. Although we are 255, we again, as the picture looks at the statistics, we note that the larger proportion is still in the low income within the African region. For Kenya, we're in the low middle. And then you see that we just second to Nigeria in terms of the population numbers, at about 12.5 million is the proportion estimated by our regional office. So this, we're still continuing to really bring out the fact that in terms of demographics, the number is increasing, and every country needs to recognize that and quickly strategize and take that approach to program for them. So in this slide, it's just comparing a little bit between the adolescents and the youth. If you were to expand the bands and look at the proportion of youth, then it would even be more than 25%. I think ADHS estimated maybe 35% or more. Again, this slide helps us to look at one of the issues that's affecting our adolescents and was again spoken about by one of my colleagues, I think Dr. Migoa from KPA, around the issue related to birth rates. So it is an issue because it affects the overall well-being of our adolescents and even affects the issues related to the socioeconomic status and how they're going to be able to progress. So in this slide, we're trying to compare the birth rates, the birth rates both for Africa, but also comparing with the region. So on the right, you can see that the birth rate for various regions, Africa, the Americas, Eastern Europe, as well as Asia, Africa still has the highest adolescent birth rate. And so it is an issue of concern because we know that the circumstances around adolescent pregnancies are often are detrimental, not just to the adolescent, but also to the child. And subsequently, the outcomes, both for health and well-being, are impacted negatively. So the focus now is to try and work towards policies and strategies that will be able to prevent or to deter adolescent pregnancies. And so we are saying that although there has been a decline in the rate overall, as you can see on the bar chart, that if you look at that trend from 2010 up to what statistics we have in 2018, there has been a decline, but this decline really is not fast enough. As we look at some of the sustainable development goals, it needs to be much higher, but at a much quicker rate in order for us to have a more positive impact. I'll skip some slides because some of them are a little more technical and maybe we want to be able to keep our guest of honors engaged. And this again just is a pictorial map of what the birth rates are. And what you can see is generally, if you remember our lower income countries for the African region, you recall there was somewhere in the Central African region. So where there was a lower income, then there was a tendency, this slide shows that you have a tendency of a higher adolescent birth rate. Kenya is colored green, and so the birth rate there is less than, the rate is less than 99, which is still, I mean, better than the rest of the African countries. But as I said, it doesn't help us meet the trajectory towards our SDG goals. I think this slide is important because we know that even from our statistics from the Kenya Demographic Health Survey, the outcomes for children and for women were directly related to literacy rate. So you've seen how eloquently our very educated adolescents have spoken. They're able to acquire knowledge, be able to adopt behavior changes that will promote their health and well-being. So in order to pass on this information and knowledge, we need a literate population. So in this slide, we looked at what is the youth literacy rate for the population of 15 to 24 by country and by sex. And we see that 23% of the youth in Africa are literate, just about 23%. So a little less than a quarter of our youth are literate. And that has a very big impact when we talk about public health interventions. But then the literacy rate was highest in countries like, Zimbabwe, which was at 48, followed by Mauritania, but lowest in some countries such as Cape Verde, which was again in the low-income countries. And we find that generally the female youth in the African region had a higher literacy rate than the male youth. So this is also a big plus. But the multi-sectoral approach, meaning that even when we think about health interventions, we will not be able to achieve them on our own. We must work with the other sectors, such as education, water and sanitation, and even child protection and social protection, all the different sectors that affect the young person and the adolescent. We will not be able to achieve what we want to achieve unilaterally in the sector of health alone. We must engage in other sectors in order to make the impact and reach the goals that these young people have asked us to prepare and do for them as they look into the future. Now going into health issues in the continent, this slide looks at the number of adolescent deaths during the period 2000 to 2016. And it shows that by and large, HIV/AIDS is still a leading cause of death in the continent, and followed by other important positive regions like road accidents. We still have infectious illnesses like meningitis, diarrheal disease, and respiratory infections. But I think what is also important is that when it comes to mortality, death, we had more deaths recorded among adolescent males than females in the African region, and this gap is gradually widening. So when we talk about the boy child, we talk about the adolescent male, we need to be able to think about interventions that will also be able to address this issue around the high mortality that we're seeing around for our males, adolescent males. And we then, this slide also goes into a little bit more related to early marriages. I think it's a larger age band, more of the youth. As I said, this was prepared for probably a more technical audience, and I want to make sure that we are engaging our young people. But the statistics we're also sharing here look around ART coverage among adolescents between the age of 10 to 19. And we note that only Algeria and Namibia exceeded the target, because the target is 90% of ART coverage among adolescents. I don't have Kenya here, but I know that Kenya generally had not yet reached that target at the time these statistics were. And if Dr. Juliet will confirm, I think we still haven't quite reached that target. This slide just re-emphasizes the big concern around pregnancy in adolescents, as we had said earlier. The emphasis is the fact that where you have low income, then the same trends are there. You're having higher adolescent pregnancies, higher early marriages, higher GBV, gender-based violence. And so these statistics are across the board, and it's more with the low income countries in Africa, but it's also affecting the middle income countries in Africa. Now, the issue of gender-based violence, which sort of relates to what they spoke about. They spoke about the fact that you get bullied and it might be digital, and then subsequently it can also be physical. As they said, if somebody likes you, if you don't respond positively, maybe somebody gets violent, and you can have emotional abuse, physical abuse, the different types of abuse that they have mentioned. But this one is talking specifically around gender-based violence. Remembering that some of the adolescents actually get into unions or are married or engage in early sexual debut, then they are exposed to partner violence. And so in this slide, we're showing that the percentage of people, this is a larger age bracket in terms of statistics, between the age of 15 to 49, who consider husband to be justified in wife beating. Just a concept, a perception, that you think it's justified to be beaten. On the left-hand side, you could see it really was in the Central African Republic, which again is a lower income, and they considered it to be justified to be hit or to be physically abused. And this perception was higher amongst the males and the females. So the cultural issues, just to emphasize the cultural issues around gender-based violence, we need to be able to address them right from the early age of adolescence, so that as they progress, you don't think it's okay to hit somebody else or to hit your spouse or your partner. And it was interesting that there were more females than males who considered a husband to be justified. And again, I think this is related to culture. So when we address the issues of gender-based violence and we look at this as we look at the statistics that adolescent health, we realize again in the programming, we need to address the knowledge, we need to address the issues around perception, and we need to empower. We need to empower both the males and the females so that their perception of themselves and of others can be able to be even more positive, that positive imagery. And we don't have a statistic here for Kenya, but I think the KDHS statistics did show. They didn't measure specifically in adolescents, and I think, but it's a mirror. It's a mirror really of the society in which our children live in. And as the young man said, a monkey see, monkey do. So what you see is what you then practice. The next slide is really just going to greater detail because gender-based violence is an important SDG parameter. It's 16.23 and 5.32. So more work needs to be done to achieve this SDG goal, and it also includes other harmful practices. For example, female genital mutilation. So with that, I hope I've given you a bit of an oversight on what Africa looks like, and the take-home message really is that almost 25% of the African population are adolescents. These really are, and it's such a young and youthful continent, which we really should be so proud of, especially as you travel and you see how other countries don't have young people. They have aging populations and the demographics have really changed. They're not able to support. But we have an opportunity to make the best and a better future for our adolescents. And they believe in us, and the statistics still show that they want us to help. Remember his analogy of the eagle. So it's a really great opportunity, and I think it's a pivotal time. The current government has put great emphasis on adolescents, and we believe we'll be seeing more developments in terms of strategy and policy. And WHO remains committed to support the country and believes in the health and well-being of adolescents. So with that, I can only say thank you, and God bless us all.
Thank you very much. As we said, the stage for the next presenter. Thank you, Dr. for that wonderful presentation. We are also having a live link for this session on YouTube. So if the organizations that are interested in getting the link, we'll be able to share through your emails or WhatsApp. So the next presentation will be by Dr. Juliet, representing the division of the status of adolescents.
Good morning once again. As I earlier introduced myself, I'm Dr. Juliet Omoha, the Program Manager for Adolescent Health, the Division of Adolescent and School Health at the Ministry of Health. So, our guest of honor, have you learned something from the previous presentation? Yeah. So, we as the Ministry of Health, we have really done so much to ensure adolescent health is a priority. Even for us just being here, it shows that over time, we have really concentrated on the extremes of age. That's mostly 0 to 5 years. You'll see many campaigns, many posters. We concentrate on adult medicine. You'll see cure for cancer inputs. You'll see adverts on how to deal with hypertension, diabetes, old age issues. But just think about it. When is the last time you've seen an advert or any poster that relates to an adolescent? If anyone has seen a poster or an advert that talks about an adolescent, please lift your hand. You see, we have a really long way to go. Just from this, if this was a study, this sample is 0% have seen a study or an advert when it comes to adolescent health. Our head of division, Dr. Christine Wambugu, would have really loved to be here. That is one person I know is very passionate about adolescent health. But today, I'll take you through the status of adolescent health and the progress towards the Sustainable Development Goals in adolescents in Kenya. Sustainable Development Goals are goals that are meant to change the world. So I'll take you through the presentation and I'll start with a question to the adolescents. I don't want to embarrass the older people unless they don't know the answer. So I'll pose to the adolescents, our guests. What is the total number of human beings in the world? You guys still do GHC, right? Special classes. Yeah, yeah, so what is the total number? Yeah, sure. Dr. Wino, please organize for a gift for whoever gets the right answer. And you have people from Population Council and also they have the statistics. Not Googling. 7.8 million. Okay, someone else, a boy now. 8.3 billion. Last one, yes, a lady. 7 to 8 billion. Guys from Population Council, I need the answer. Even those in research and or yes, please.
8 billion as per November last year.
8 billion. Yes. So Dr. Wino organized for a gift for who said 8 billion? Yes. So Dr. Wino will give you a gift. Next question. How many human beings are in this country? How many people are in Kenya as we speak? Adolescents, please. Or you're all adolescents for today. Adolescents. How many people live in Kenya right now? Have you given the list? Yes, please. 54 million. Yes. 49 million. Last one? 49, yes. Last response? I pick randomly. The amount scared, everyone is looking down. So who will give us the exact figures? Isabella? Total number of Kenyans? Okay, over to the adults. How many people are in Kenya? Surely they are Kenyans. You see, they still want to respond. Yes, Charlotte? 55 million. So no one in the population field is willing to comment. So out of all the numbers that you have mentioned, sorry, we have more hands up. Sorry. Yes, please. 53 million, yes. The same. Do you guys agree? Surely. Do you guys agree? No. You guys, you need to pull up your socks. Yes, Montana? Yes. Okay, let's take the census since it's the one that. I'll continue with my presentation. So globally, we have 1.8 billion adolescents and young people. In the world, there has never been a time when we had this number of adolescents and young people. In Kenya, we have 24% of our population in Kenya. That's a quarter of Kenyans are adolescents. There are approximately 11.6 million adolescents in Kenya, which is quite close to the 13 million that one of our guests actually mentioned. Out of the 11.6 million, we have 6.34 million between the age of 10 to 14 and 5.28 million in late adolescence. So, as Dr. Makeba had mentioned, we organized this Kenya National Forum for Adolescent Health and Wellbeing because one, adolescent health has to be a priority. Whether we like it or not, we need our future to be certain and we need to actually build our leaders for tomorrow. And this is a global initiative. That's the Global Adolescent Forum 2023. And it's a campaign for young people for change, which their slogan is 1.8 billion young people for change. So in regards to what we have done as the Ministry of Health in terms of adolescents, we've had Chief mentioned Kenya demographic health surveys. We've had various surveys that have been done in the country. But think about it. Before this year, no one had ever heard of the adolescent survey because the government was keen on it and decided in 2019 to do the first Kenya adolescent health survey that was launched like 4 months ago. So I will highlight as I go what are the key things that stood out in regards to adolescents and try and match with the progress that we have in regards to the Sustainable Development Goals. So in our Kenya Adolescent Health Survey, which was huge for us as a division and also as a ministry, we conducted it in 44 counties, but there was limited access in Lamu, Tana River, and Marsabit due to flash floods and insecurity. The sampling frame was based on the Kenya National Bureau of Statistics enumeration areas, and it was a national representation by having 3,800 adolescents, 408 health facilities, and 380 schools. So I'll go through specific topics as we go, just showing you where the status of adolescents as a country. According to Adolescent Health Survey, there was undernourishment among adolescents at around 10%, and it was quite high in the northern part of the country at 40%. 3/4 of adolescents have a normal BMI, which when we see this, we be like, great, our adolescents are doing well. If you have 3/4 of them normal, but think about it. 1 in 10 adolescents are malnourished. This is mostly in the arid and semi-arid areas. 1 in 10 adolescents are obese, mostly in urban centers. And then 1/3 of adolescents between the age of 10 and 14 have adequate dietary diversity. This has improved over time, especially in adolescents between 15 to 19 years, which was at 46% as per the KDHS 2022. 1/3 of adolescents live a sedentary lifestyle. This is a statement that I want everyone to take note when it comes to nutrition, because the nutritionist in the room can say this is a red flag. Why are our adolescents living a sedentary lifestyle? To our guests, a sedentary lifestyle means a lifestyle that there's limited activity. Why? We are watching too much TV, we are doing PlayStations, we don't want to go outside to play, we don't do anything that actually motivates our bodies to move around. So 1/3 of the adolescents live a sedentary lifestyle. Through this and poor nutrition, these are risks for non-communicable diseases in adulthood. These diseases include diabetes, hypertension, just being obese, and cardiac issues. Kenya has made great strides in implementing school meals and nutrition strategy to reduce the causes of malnutrition, including anemia, in school-age children nationwide. So Kenya is also implementing WHO recommendations on school-based deworming, annually deworming 6 million school-age children in regions endemic for soil-transmitted pelvic and schistosomiasis. So there's the deworming program that we are working with different organizations. This is in line with SDG 2.11 to reduce the prevalence of low BMI among adolescents from 10% to 5% by 2030. When it comes to oral health, adolescents, this forum is for you. How many of you have ever visited a dentist? Oh, that's great. So when we did this survey, we realized that 85% of you guys had a toothbrush, a half of 10 to 14-year-olds brushed once a day, and 3/4 of the 15 to 19-year-olds also brushed once a day, and only 2% of adolescents reported ever having visited a dentist. When it comes to adolescent HIV, globally, there are 1.3 million new HIV infections, 630,000 AIDS-related deaths, and in East and South Africa, there are 500,000 new infections and 260,000 AIDS-related deaths. In Kenya, adolescents living with HIV are estimated to be 91,634, and 2,275 deaths are due to HIV or AIDS-related complications. 6,166 adolescents contract HIV every year. This is a concern because They actually contribute a third of all the new HIV infections in Kenya. The Kenya AIDS Strategic Framework set out quite ambitious targets to reduce HIV by 75%, reduce AIDS-related mortality by 50%, microeliminate viral hepatitis, reduce the incidence of sexually transmitted infections and HIV-related stigma to less than 25%, increase domestic financing of HIV response to 50%. This is in line with SDG 3.31, which is to reduce the number of new infections among adolescents by 75% in 2030. So think about it. The slide I've gone through, if a third of the new infections are from adolescents, we need to actually strive to ensure that these numbers go lower. There's adolescent TB. Adolescents, as much as they are considered quite a healthy cohort, they don't fall sick often, you will not find many of them in hospitals. They are also affected by different conditions. One of the main conditions is adolescent TB. Globally, there are 10.6 million people who fell ill with TB in 2021. Most TB cases were in Southeast Asia and Africa, Southeast Asia being 45% and in Africa 23%. The 75% reduction in the global TB deaths and 50% reduction of global TB incidence. In Kenya, TB cases were 251 per 100,000 of the population. That's still in 2021. There are 7,500 childhood TB cases that were notified to the National TB Program. Out of all this, 68% were adolescents aged between 15 to 19 years. Through commendable reduction in TB, though there's commendable reduction in TB seen, we've fallen short of the global target of 90% reduction in global TB deaths and 80% reduction in the incidence by 2030. The National TB, Leprosy and Lung Disease Strategic Plan, it outlines the intervention to intensify TB prevention in schools and commits to increase the case detection for this age group to 70% from 35%. It also outlines new service delivery models that will be adopted to help eliminate the barriers children face in assessing TB prevention, diagnostic, and treatment. This is also relates to SDG 3.32 to reduce TB incidence among adolescents by 70% in 2023. Malaria was mentioned, and as much as you think about it, most of the time we get campaigns, mostly distribution of nets. I recently interacted with adolescents in Kisumu. It was a project we had in Kisumu, and most of them felt they've reached of age, they shouldn't use mosquito nets. So we are having a knowledge gap. They're seeing mosquito nets are for those under 5s for the pregnant women. That's what they told me. For those small babies and women who are pregnant. But think about it, globally, we're having 247 million malaria cases in 84 malaria endemic countries. In Kenya, it has become a significant public health concern. 3/4 of the population in Kenya is actually at risk of infection. Adolescents aged 10 to 14 years have a high prevalence of at 7.6%. What's the government doing? The Kenya Malaria Strategy 2019 to 2023 outlines intervention to protect 100% of adolescents living in the malaria risk areas through access of appropriate malaria preventive methods. This goes with the SDG 3.33 to reduce malaria incidence among adolescents 10 to 14-year-olds from 7.6 to 5% in 2030. I really love this slide. Anyone who knows me personally or follows me online, because I have a page that educates on pediatric issues and adolescent health issues. I'm an HPV vaccination champion. I'll ask this now, the adults or the older adolescents, you can respond. How many of you have heard about the HPV vaccine? Heard about the HPV vaccine? Why are you guys lifting your hands like this? I'll not ask you another question. Great. Let me see from this side. How many of you have heard of the HPV vaccine? Good. I like that students have also heard of it. So in this room, how many of you have received the HPV vaccine? Amazing. Can you just stand up for people to clap for you? Oh, there's another. Oh, sorry. Yes, please stand so that people will appreciate you. Thank you so much. HPV vaccination is something that we have to educate everyone in this country about. Why is this so? Every day, 9 women in Kenya die because of cervical cancer. So when we talk about the HPV vaccine, it has an excellent safety profile. It has very high efficacy against targeted HPV infections and diseases including cervical cancer. And we actually give it to adolescent girls to prevent cervical cancer in future. Right now, the Ministry of Health is administering to girls between the age of 10 to 14. So there's the 90, 70, 90 targets. If you don't get anything from this slide, this is what I want you to take home. We target for 90, 70, 90. 90% of girls to be fully vaccinated by the vaccine by the age of 15. 70% of women to be screened with high performance tests by the age of 35. And again, a repeat done at 45. And 90% of women identified with cervical disease receive treatment. That's 90% of women with pre-cancer treated and 90% of those with invasive cancer managed. So we are progressing towards the SDG 3.41 to increase the proportion of 15-year-olds, adolescent girls, fully vaccinated with HPV vaccine to 90% by 2030. I'll pose this question to the adults. Adolescents, you guys are smart. Let's pose this side. I'm not saying you guys are not smart, but should boys be vaccinated against HIV? Why? The carriers, okay? So we as a government and the Division of Adolescent and School Health, we champion for this. It's just that we are in the process of first doing the girls. Over time, we will actually commit to the boys. But if in case you have a son who's around that age, there are private facilities. I can see the team from Gatros. Do you give the vaccination to boys? Yes, so if you are able to afford, you can visit any private facility to get the vaccine. So during this skit, and as the adolescents were talking about their challenges, one of their main challenges was mental health. Globally, 1 in 7 adolescents suffer from mental health condition. And suicide is the 4th leading cause of death amongst 15 to 29-year-olds. In Kenya, suicide among adolescents is actually a rising challenge. Approximately 4% of adolescents report suicidal tendencies. More than half of the adolescents, that's 54.5%, reported that they actually had an adverse childhood experience. And those who had the adverse childhood experience had higher incidence of suicidal ideation and attempts of about 6%. You can see this is huge. There's this thing we need to demystify, that adolescents are okay. Si anaishi kwangu, halipi rent, anakula, why would the child be stressed? That's what we want to demystify. That mental health issues we really need to address because they go through a lot, but we do not give them the avenue for them to express themselves. So we actually need to enforce that mental health should be a priority when it comes to adolescent health. So the Kenya Suicide Prevention Strategy of 2021-2026 aims to reduce suicide mortality, through amendment of relevant legislative frameworks and policies of effective suicide prevention and developing and implementing better system on suicidal risks surveillance. They've done this through improving access to mental health services, including the establishment of suicide prevention helplines and integration of care at the community and primary health level. Kenya is currently adopting the WHO UNESCO, making every school a health promoting school guidance, which defines the socio-emotional well-being environment that also helps reduce the incidence of suicide among adolescents. So we are doing this as we progress towards SDG 3.42 to reduce suicide mortality rate among adolescents from 4% to 1% by 2030. Do you think we can achieve this? Be confident. Yes, we can actually achieve this. So another thing that came up, I was just hearing all the valid points they were raising, and I'm like, should I even present? But then I have to give you the numbers of the ground. When it comes to alcohol and tobacco use, that's drug abuse. Globally, 16% of drinkers aged 15 years or older engage in heavy episodic drinking. Harmful use of alcohol results in 3.3 million deaths each year. According to Adolescent Health Survey, alcohol use was reported in 10 to 14-year-olds at 2%, and 15 to 19-year-olds, those are the older or late adolescent, at 9%. According to KDHS 2022, it reported almost the same figures, 15 to 19 at 3% among females though, and 6% among males. So alcohol use was actually higher among the males. When it came to smoking, annually there's 1.3 million non-smokers who die from exposure to secondhand smoke. Now this is to the adults. You might think, oh, I'm done smoking, it will not affect my child. Our aeration already as a country, we interact on less than 1 meter. There's that child, there's that sister next to you. You'll find that this sister who does not smoke but is constantly with you, who is a smoker, might actually suffer from the effects of the smoking more than you do. So there are 8 million tobacco-related deaths yearly. According to our health survey, cigarette smoking reported 10 to 14-year-olds at 0.7% and the older adolescent at 3%. Tobacco use among the 15-year-olds was at 1% for females and 12% for males. Now here is where we have that deep discussion. When you ask adolescents around you, because one thing we have realized, at least 95% of you interact with an adolescent every day in your daily life, even if it's just passing through the estate. That's a form of interaction. So, do you think our adolescents right now know the brands for cigarettes? The Sportsman, do they know it? Can they name more than 4 brands? I want to tell you that you're wrong. Most of them we only do 2, like Dunhill and Sportsman, and this is what anytime I meet adolescents I ask. Why is that so? There are newer tobacco agents right now in the country that are a menace more than smoking. You know what that is. Yeah. We have Velo, which is good that I hear it's getting banned. It comes in, they're like pouches. Yeah, the small pouches. You put under the tongue, it gives them a weird high. There is shisha all around. And when you think about it, we talk of Velo, we talk of shisha and other tobacco agents. These are things that these adolescents can easily assess. Some told me that when you go to a supermarket, you'll be told, I cannot take the beer because you're not 18, but they can buy Velo. So there's that imbalance in that we are still struggling with tobacco use or nicotine-less substances in this cohort, but there are also, what are they called, vapes, which can disguise as parents and all. You as a parent, you're thinking, my adolescent is a hard worker, yet that is something that they smoke every other day. So when it comes to positive parenting, let us be keen parents, let us be intentional parents for us to pick out all these things. So the government commits to eliminating marketing of alcohol and cigarettes to children and around school premise and strengthening the implementation of the WHO Framework Convention on Tobacco Control. This is in the progress towards SDG 3.52, reduce the harmful use of alcohol among adolescents from 9% to 4% by 2030 and eliminate the use of tobacco products among adolescents by 2030. When it comes to road traffic injuries, globally there are 1.3 million people who die annually from road traffic crashes. GPD and UNICEF estimate road traffic crashes are among the top 5 leading causes of adolescent deaths globally. So in Kenya, according to KDHS 2022, 135 deaths per 100,000 population and 1,466 severe injuries per 100,000 population were from road traffic accidents. Now let's go to the adolescents. In our health survey, we actually found shocking information because out of all those 3,800 adolescents, 95% declare they don't wear seatbelts, whether they are in a private or a public motor vehicle, and 99% do not wear helmets when riding motorbikes and bicycles, which the correct use can lead to 42% reduction in the risk of fatal injuries and 69% reduction in head injuries. Wearing a seatbelt will reduce the death among drivers and the occupants by 45 to 50%. And let's also encourage our new moms. It is not safe for the men in the room. You're driving your mother, your wife, the mother to your child to the clinic, and the mother is seated at the front seat holding the baby. It does not mean that having the mother at the back seat makes it more safe for her, but let's start from day one. As a pediatrician, back when I was in clinical practice, any mom who would come to the clinic, I always used to tell them, did you come with your baby in a car seat? Because you might want to risk your life, but this child has a life of their own. So let's encourage for the medics in the house. Every mother should actually invest in a car seat if they're able to protect our children on the roads. So the goal of the Kenya Violence and Injury Prevention Action Plan of 2018 to 2022 is a 50% reduction in road traffic fatalities. This is in line with SDG 3.61 to reduce the death rate due to RTAs among adolescents by 50% in 2030. Then there's something that came up in regards to adolescent sexual and reproductive health. Kenya Adolescent Health Survey and KDHS report a median age of beginning the menses or starting your period at 13 to 14 years. The median age for the boys adolescent deepening the voice is 14 years. So the young man who presented and felt that it's not yet time, you still have 14 years old is still the median age. 9 out of 10 female adolescents have been able to access sanitary pads both from home and as part of school sanitary pad program. A third of adolescent girls, that's 10 to 14 years, and a quarter of the 15 to 19-year-olds reported that they did not know that having your periods meant that you could be pregnant. I'll pose this question to the room. Who is failing on this? If adolescents don't know, by the time I'm getting my period, I can be pregnant. Who is to blame? I'll continue. Adolescent birth rates, that's adolescent births per 100,000 female adolescents, have been steadily declining and is now at 73 per 100,000, previously at 150 per 100,000. And most teenage pregnancy occur amongst adolescents, mostly at 18 and 19-year-olds, but this does not mean it doesn't happen to the 15-year-olds. There is need to have a multifaceted approach to address the reduction of adolescent birth rate. To this end, the Ministry of Health is finalizing the Adolescent and Young People Sexual and Reproductive Health Policy and Social Behavior Change Implementation Plan. Under the universal health coverage, community health promoters will provide health information and community health interventions to reduce the adolescent fertility further. This is to reduce by 50% of the adolescent birth rate by 2030. There is female genital mutilation, FGM, which is a violation of the human rights. It's mostly carried out on girls between infancy and the age of 15. More than 200 million girls and women alive today have undergone FGM in 30 countries in Africa, Middle East, Asia, where FGM is practiced. In Kenya, 3 out of 4 girls who have experienced FGM experience it before the age of 14. At the Generation Equality Forum in 2021, Kenya, as a global co-leader of the Action Coalition on Gender-Based Violence, made 12 commitments to end all forms of GBV and FGM by 2026. This is in line with SDG 5.32 to eradicate female genital mutilation or cutting by 2030. What has come out strong from 2 presenters is the issue of violence, which is happening in our community, and we need to empower adolescents, as Dr. Makeba said. We need to give them the knowledge that it is not okay. According to KDHS 2022, 20% of the women 15 to 19 years had experienced physical violence. And actually in our adolescents, almost a quarter of adolescents have experienced physical violence before the age of 18. According to our adolescent health survey, 7.9% of female adolescents and 5.3% of male adolescents reported having ever experienced sexual violence. Out of this number, only 1 out of 10 male and female adolescents who had experienced this revealed that the perpetrators were who the perpetrators were or whom they informed the incidents about. So I'll pose another question that you can discuss during the Pass the Mic session. If you are having sexual violence and in adolescents, these are 10 to 19 year olds, but then only one will be able, if you have 10, only one will be able to report. Who is failing or why are these adolescents not open to us and to come and tell us we have gone through 1, 2, 3. So when it comes to adolescent health, I cannot talk about adolescent health without talking about the universal health coverage. About 2 billion of people are facing catastrophic and impoverishing health spending. COVID-19 actually missed most countries. It disrupted the essential services in like 92% of the countries, especially at the height of the pandemic, that is in 2021. In 2022, 84 countries could still reported the disruption. Achieving UHC is one of the targets of the nations of the world set when they adopted the 2030 Sustainable Development Goals in 2015. Government has been implementing EduAfya, which is set to be merged under the broader UHC scheme. This is in line with SDG 3.82 to increase the number of adolescents covered by health insurance by 75% by 2030. We need to promote learning, competence, education, skills, and employability for all adolescents. If you can look at the screen, the numbers were really good in 2019 when it came to enrollment. What stood out was almost 109% rates of enrollment. The retention was really good in primary schools and secondary above 80, and the primary completion rate was 82%, while transition from primary to secondary was at 95%. In our adolescent health survey, we realized that 9 out of 10 schools had improved water sources. 60% of adolescents had missed school 1 to 5 days in the last 3 months of the survey due to health-related issues. 7 out of 10 schools provided sanitary towels, but then here comes the gap where only 15% of schools had any healthcare personnel, and only 10% of schools had a sanatorium or sick bay, and of these, only 3% had them within the school compound. When it comes to issues of disability, which over time have been ignored, only a third of the schools sampled had disability access. 32% of schools sampled had functional school health plans, with 90% of them being managed by teachers. When it comes to promoting adolescent connectedness, positive value and societal contribution, knowledge and skill needed to promote sustainable development, including, among others, through education for sustainable development and sustainable lifestyle. This comes in the form of human rights, gender equality, promotion of a culture of peace and non-violence, global citizenship, and appreciating that there is cultural diversity. This has been embedded in the CBC curriculum. Programs that are giving guidance to adolescents, parents, community leaders have been initiated through the Ministry of Health, Ministry of Gender, and NCCD. So in our Kenya Adolescent Health Survey, before I go to that point, how many adults know that we have adolescent and youth-friendly health services? Okay. Quite few. In our health facilities, there were 62% of health facilities that offer adolescent and youth-friendly health services. We really applaud, yay, we have 62% of facilities doing this, but half the adolescents felt that they were not guaranteed confidentiality, so they were not going to these clinics. which if it's more than half, it means we are actually not on the right track, and we are planning to actually improve on that. Promoting agency and resilience of adolescent health in programs, the strategic directions. We are having the Kenya Adolescent Health Strategy, Policy and Strategy 2023 to 2027, which I'll just touch on, that develop adopted guidelines of meaningful engagement of adolescents in designing data-driven and evidence-based policies and programs, including program implementation, governance, monitoring, and evaluation. Agency and resilience of adolescent health programs will also be achieved through global or voluntary national review for the AWCs and through accountability, country profiles, and scorecards. This is in progress towards the SDG 16.7 to ensure responsive, inclusive, participatory, and representative decision-making for adolescents at all levels. So as I mentioned, our current adolescent health policy and strategy is 2018. We are currently in the works of finalizing the adolescent health policy and strategy 2023 to 2027. I don't want to go so much into it. Yeah, so I'll just take you through, I'll read the pillars, because when we do the launch, I still want you guys to attend. If I tell you everything in the policy, will you guys come? No. So I will just read out the 6 pillars that are in the policy, so that when you get my invite, and I'll also invite the adolescents on the launch for the policy and strategy, you will know the 6 pillars. 1, promoting disease prevention through health promotion and provision of age-appropriate health information. 2, promote health system strengthening for adolescents and young people. 3, promote a positive legal and policy environment for adolescent health. 4, to promote elimination of harmful social and cultural practices and non-communicable diseases risk factors in adolescents. 5, to empower adolescents to take control of their health. And the last one being adolescents in humanitarian fragile setting. So we have this Kenya Adolescent Health Survey Visualization Dashboard. So you can take photos of that link at the top. You can just key it in and you'll get all the information you need to know about our survey, from the numbers and what we did. So just take a photo of that. You'll be able to get all the information that I have shared in regards to the health survey. So that was my presentation on the status and our progress toward SDG. And thank you so much for your time.
Thank you very much, Dr. Juliet, for such a wonderful presentation. A round of applause again. Since that presentation was between us and breakfast, we'll go for tea break for exactly 15 minutes. Tea is served in various stations. And then there is an outside area where you can, is it called a veranda or what is it? Just after this, it's a lounge or a balcony, depending on the kind of house you come from. So, so you can, so that you don't congest the area, you can just take your tea, then go to the balcony. Yes. Thank you very much. So we'll begin from there after tea break. 15 minutes. The time now is 11:30. Murudi hapa. Ongeza 15 by 11:30 45. Yes.
No, sina kitu.
Hiyo muziki yako kusikia story yangu from YouTube. I think it's connected. You know, like this. This is me. Nini? Nataka ile kuna kitabu nitakupea. Mimi na old book. Mimi na old book. ID. Relaje sitaki. ID.
Niko mambo.
Kama umewakilisha.
Nakuonyesha hapo.
Unikaribisha. Yes, I see guys. Msanii mimi si. Hapa nimekuja tu hapa ni whatever mpaka YouTube. Mimi hapa jina ni Esther. Yes, na Jafar na hiyo group yote. Hiyo group. Sasa sisi wale sound. How can I see this video and sound at the same time?
Iko sawa. Mimi nimeweka hiyo iko sawa hiyo.
Good sound, but they are daily. Simuje kwa YouTube already. Ndio ile song one. But hakuna bei.
Wacha I wish unajua mimi wanafanya hivi sasa. Ningetoka usikize. Kwa watu wamalize.
Sawa. Unajua kumaliza tu commit hizo. But we just try it. Haina shida. I'll try it before you. Wewe nitafuta tu wenyewe mpaka
Yaani msamiati ongeza. Nimepata kile. Sasa sijajua nilimwacha kile. Zungazunguka hivi tunaenda hapo juu. Wacha.
So I forgot to eat. Then I play this one. Yeah. Kindly call your next mates, villagers. You want to begin? I can see you don't want to leave at lunchtime. Huh? But some of us, this is our work, so we have no problem having you until 5. Because there'll be lunch. And the next meal you're going to take some. So there's no problem. Even if you want us to stay until 5, we have no problem. So kindly call your villagers, your estimates, table mates, or your friends who have not come. Because we have a very serious performance from the city coming. So what are your music? So Ariana, karibu, kwanza na hii kwanza. Asena kama forward. Kila mtu asimame. Everyone to rise up. Tumemaliza the active part. As we do that activity, remember kuna watu wa vitambi. Please, the young ones, give us vitambi. Kuna watu wa vitambi, watu wa 6-pack. Please, consider so we can all of us rise up. It's an adolescent forum. So, hata wale wa 50 plus who are almost retiring, you must do all these things. Welcome. Asena will take us through that session together with our invited guests. Lakini you might find a more flexible than some of you.
Hi. Saseni. So tunafanya dance ya adolescent. Na then nataka join involved pia tapick 5 people randomly penye tu uko ndo utakuwa. So kuna stand moja ya hiyo tukitoa utaenda ukigani gani pia utatufanyisha. Yes, you. Huyu the jet. Oscar, then mwenye intervention next please tu atakuwa tutaangalia sio the lady in black. Respect. See the list. What's your name? Vined. Then the teacher mwenye amevaa mwenye aniangalia. What's your name? Daniel, Ines, nimebakisha Oscar, then pale nyuma ya the gent mwenye kumusha kabisa. Morioki, Oscar, Ines, Daniel, one lady wa musha. Haya chela wetu. So, tuweke siya madembele, tunafanya childhood nini na mna cooperate, si ndio? Haya, tuweke wimbo. Haya, tuanzeni. Tuanze.
We cannot underestimate the energy. Energy of this youth and adolescent. Consider determine, please. No one to determine, they have to rest. No one to determine. Also consider we have ties and suits. We cannot jump like that. So, you know, this youth will give them time, they can turn us into athletes. Thank you very much for such a wonderful presentation. Thank you for at least hiyo chai yote imeisha. Next time nilisema mconsider watu wa kitabu. Now teacher Daniel, you decided not to give us a sample of the dance. So we'll still give us that one at the end of this session. Thank you very much. Next is LBCT. And I welcome Ariana Kamau. Ariana, let's clap for ourselves for doing very well. Ariana Kamau. Thank you. Welcome.
Distinguished guests, ladies and gentlemen, my fellow teens, good morning.
Good afternoon.
My name is Ariana Kamal. I am 13 years old and I'm really grateful for this opportunity to tell you all about how it is being a teenager in Kenya. I first felt like a teenager when I got my first period. Being a teenager in Kenya is a bittersweet experience now that we're growing in the digital era. There's peer pressure from your peers, social media, and many others. One simple comment can make your world shatter. Mental health is one very important factor in the adolescent age. If you are getting bullied, for example, you may go into subconscious depression. The positive side is that now we can have the conversations that were heavily avoided 10, 20 years ago. People in society are still stereotypical towards teenagers. Society expects teenagers to know what they want to be in the future and they're in a self-discovery phase. We're still trying to get the hang of life. It adds pressure for us to know what we want to do. I wish my parents knew that teenagers find it hard to open up and introducing topics that are avoided would help us communicate better. But they were raised in a totally different era. What they didn't know then is different from what we do now. They are trying their hardest to understand how to parent us. Sexual activity is happening between teenagers and they don't know how to go about it. How to use contraception, how to abstain, we are clueless. The troubles teenagers cause is coming from somewhere in them, they are struggling. Alcohol is now an escape for teenagers. They get drawn out of reality by being the influence of alcohol and drugs. I wish my parents knew that relationships amongst teenagers are very common. If the relationship doesn't work, it can affect the teenager's body image, mental health, and even their perspective of love. What I wish doctors knew is that if there was a situation like an overdose, they should explain to the teenager about what the drugs they used and the effects it has on their bodies before telling their parents, and they should explain it in the most understandable way possible. Even when we come to the hospitals, statements like you should lose or add weight should be said very sensitively. On a personal note, in the school that I go to, I am a mental health ambassador and I help students find their safe space and open up about what they're going through. This has helped in the welfare of the students. This is just one of the ways young people are taking charge of their health and well-being. My challenge to you all is to empower other teens to take care of their health and well-being. I'll allude to what Dr. Juliet said, there's nothing for us without us. With all that, thank you for listening to me.
Thank you for that. Wonderful presentation, Ariana Kamal. Let's clap for her again. Yes, just.
Hello, Saseni. Asena from LVCT. LVCT imefanya ile kitu wasichana wamejijua place ya GBV tuko hapa tunafanya kazi nzuri, si ndio? So tungetaka kuwafunza staff yenye mkienda huko nje inamtianga wasichana. When you go for walks tunaitumianga kila tukio ni hizo nishangaje awareness tunafanyanga sana na wasichana wanaipenda na imemtia wasichana. So my boss tell that yes, tunaamka si sote.
Hello again. Hi. I can't go there have a big voice today. So we are being blessed that we have
Adolescent with us. So kindly naomba tusimame pamoja nasi. So this is something that all of us, if we can stand actually, if we can stand. So from what we've read and from the statistics, we've seen that gender-based violence is something that is a big thing. Sexual violence again is another thing. So we do something called safe spaces, and in our safe spaces we teach the HYW on how to awareness about their bodies, but we do it in a different way. So if I touch somewhere, we say hapa kwangu. Sawa?
Sawa. Ni mara mbili. Haya, don't touch him. 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 Tia muifani na sai.
Hello, let them see you now. You see, we told you all of us are adolescents. I do the introduction, someone saying adolescent at heart. And right now it's adolescent practically. Like it is those parts telling us to touch you. Let's continue. No, let's be serious. Let's just
So, we want to assume that, and they actually say that we assume they do not know, yet they know. True or false? That's what they say. So we cannot assume they do not know the breast. They actually even explain their body changes. So this is how it is very educative and entertaining at the same time. So nikisema, don't touch him. Unaisema na hapa kwa busi. Unasema hapa? Aya, don't touch him. 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 Sasa we continue, we go to the second phase of the song. Hapa sawa. Hii kwa stanza 1. Sasa tunaingia bridge. So, we remember the song is my private part, si ndio? But sasa kwa hii don't touch, tunaendelea kwa Kiswahili, si ndio? Nasema ukinishika nitakusema, utafungwa jela, utakosa kazi, utalia sana. Hapo sawa? Sawa. Ukinishika nitakusema, utafungwa jela, utakosa kazi, utalia sana. So we are doing it with oomph. Don't touch it. 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 Ukinishika nitakusema, utafungwa jela, utakosa kazi, utalia sana.
Don't touch it. Don't touch it. You have to maintain the visiting, we told you this is our work, so as we have no problem. So let's continue. In the spirit of very short presentations, we'll have very few presentations before we hand over to Dr. Jerry, which is a very important session of this meeting. HRC, are you ready? PowerPoint or this is that one to make it work easy. You can just introduce yourself as Adolescent speaking.
Yes, I wish I had something more exciting. I enjoyed that. Usi Tachi hapa kwangu. But I am Caroline Kabiru. I work with the African Population and Health Research Center. We are a Pan-African Research Center, so we work across Africa, but we are headquartered here in Nairobi, and then we also have an office in Senegal. So I'll just be highlighting a few findings from the Kenya National Mental Health Survey. I'll start here because I'm vertically challenged. And it's actually good that we had the presentation from the adolescent survey that was conducted, because I feel that the more you get similar data from different areas of different sectors, then you're able to say perhaps we're getting closer to the true picture. So I actually saw quite a lot of alignment with that. So why did we do this survey? I think when you spoke, you mentioned that the survey that was done was actually the first nationwide survey on adolescent health. So when we're speaking specifically about mental health, there's actually very little that's known about the overall prevalence. And the work that was done by the Ministry of Health is actually our first attempt at having national data. So a lot of the studies tend to be small. They focus on perhaps one area, Korogosho, Nairobi, or another county. They often tend to have very small sample sizes, so 500, 300. And many of them will use symptom scales. So you're asked, did you experience these symptoms? Rather than an actual diagnostic tool that can indicate whether a young person really does have a mental health problem or disorder. So with that, it becomes very hard to plan. Where do you invest? What do you look at? And that is what this work was trying to address. And we know, Dr. Juliet spoke about it, when we think about SDG 3.4, it actually speaks to mental health. So we need to have the data to be able to track progress on that indicator. So what was the survey? The Kenya National Adolescent Mental Health Survey. It was a nationally representative survey of adolescents and their caregivers. We were aiming to determine the national prevalence of mental health problems and mental disorders, and I'll explain what the difference between those two is. We were also trying to look at the risk and protective factors, to look at service use, but because of time, I won't focus on the last two objectives. So in terms of the survey, we did go to every county. What we did was we randomly selected 14 counties. And then in those counties, we randomly selected a number of enumeration areas. And these are just demarcations of areas that are used for something, to put it in a simple way. And then in those, we went to every household, then we found out which households have adolescents, and then we randomly selected those that had eligible adolescents. So we did 5,155 interviews, and we were interviewing both the adolescent and their parents. They were 10 to 17. You might ask, adolescents is 10 to 19, why 10 to 17? It's because one, some of the disorders that we were assessing required a caregiver to be there, and we know many 18 and 19-year-olds are probably in school or they are working and they're not living at home. And also the diagnostic tools we were using are actually validated for 10 to 17-year-olds. So that's the tool we were using, and I won't go into details about it. But in terms of the disorders, there are many disorders. So we could only assess a few mental health disorders, those that have been shown to be prevalent in other surveys. So first was attention deficit hyperactivity disorder, also called commonly as ADHD, anxiety disorders, major depressive disorders, post-traumatic stress disorder, and conduct disorders. And when the young people were speaking to us earlier, they actually mentioned some of these words. They mentioned stress, they mentioned depression, and they mentioned anxiety. All those really resonate with the issues that young people may be facing. So I said we were looking at mental health problems and mental disorders. So the DISC-5 has a set of diagnostic criteria. For someone who meets some of them, but not all of the criteria to be said to have a mental disorder, then they're categorized as having a mental health problem. Those who meet all the diagnostic criteria are the ones who are considered to have a disorder. So that's just a graph showing who we were talking to in terms of the sex differences, male and female, slightly more females than males. In terms of age, 54% of them were 10 to 13, and then 45% of them were 14 to 17. So,
Mental health problems are common in adolescents, but there is no difference in prevalence by age and sex if you just look at it overall. I was computing when Dr. Juliet presented. She said 1 out of every 7. And if it's about disorders, the numbers actually align. Adolescents have a mental health problem. We translate that into numbers. Today, I'm still not sure what the number is of the number of adolescents, but let's go with the 13 million. It means there are 5 million adolescents in Kenya who are struggling or living with a mental health problem, which is a large number. So I say overall, if you look at it, there's no difference by age, there's no difference by sex. If you break down the mental health problems into different categories, then we begin to see some differences. There's really no difference between males and females, just over a quarter of them. But some of the other mental health problems, we do see significant differences. So for example, men or males are more likely to have conduct disorders. They're more likely to report problems with inattention or hyperactivity. If we look on the other side in terms of age, then we see that older adolescents are more likely to have report conduct disorders, post-traumatic stress, and depression. In terms of mental disorders, so now these are the people who meet all the criteria to be diagnosed as having a disorder. That is 12.2%, which aligns with what you presented, which was 14%. So you can see, we can say, yes, we are getting close to the true, perhaps, representation of what the problem is. So 12% of adolescents met the diagnostic criteria. Again, anxiety disorders are the most prevalent, followed by ADHD and the others. Again, the disorders don't differ overall. If you look at the overall number between boys and girls, or between younger and older adolescents. But if you now break it down into the specific disorders, then we begin to see differences. Males or boys more likely to present with ADHD and conduct disorders. For this is just looking at differences by age. Again, overall, no difference between younger and older, but if you break it down by type of disorder, then you do see differences. Younger adolescents are more likely to report ADHD than those who are older. Then in terms of conduct disorders and major depressive disorders, those are more common among the older adolescents. What about suicide? I think the target is to go down to 1%. We found that 4.6% of adolescents reported suicidal ideation. That is having a serious thought about taking one's life. And 2.1 reported that they had ever attempted suicide. So yes, I agree with you. It is attainable. We can reduce that to 1%. Over 80% of those who have had that serious thought of taking their life had a mental health problem in the last 12 months. So it really says we have to do something about the 44% who have mental health problems if we are really trying to reduce suicide. What about self-harm? So self-harm is doing something deliberately to injure yourself and not necessarily, and not killing oneself. This could be things like cutting, where young people will cut to harm themselves. So slightly more than 4% reported that they've ever done something to harm themselves, with 1.2% reporting self-harm in the last 12 months. Almost all adolescents who reported that they had done something to harm themselves reported a mental health problem. So again, we have to find a way to reduce that 44% if we are to get to the 1% targets that we're hoping to get to. So what is really, if you're to take home a message, one, it's that mental health problems are common. 44% is high. If you think about your average secondary school, in our school we were maybe about 90 to 100 in just Form 1. Just under half of us would be suffering from a mental health problem. That's a big number. Second is the issue of suicide. Reaching our suicide prevention goal requires that we address mental health problems. So it is critical that we target adolescents with mental health promotion and prevention interventions in line with SDG 3. But when we are doing so, let's remember that adolescents are not all the same. If we are thinking about addressing depression, perhaps it's older adolescents, so we need to be very careful about how we reach older adolescents. Because even when you're doing other interventions, we talk about age-appropriate sex education, we might also need to think about what is age-appropriate mental health education or interventions. So I'd like to end by just saying, first of all, the slides that are presented here were developed by a young lady, Sally Odunga, who is not here. She was actually making the same presentation in a conference in South Africa, and she did an amazing job. I hope I've mirrored her enthusiasm. The room was full of excitement about how she presented, so I want to acknowledge her first. But I also want to say that the National Adolescent Mental Health Surveys were not just conducted in Kenya, they were also being conducted in Vietnam and in Indonesia, and our partners are highlighted there. But within Kenya, we couldn't have done this without the support of the Kenya National Bureau of Statistics and the Ministry of Health, particularly the Division of Mental Health, who spent a lot of time guiding us with our sampling and also interpreting and looking at the tools to make sure, because these are global tools, we needed to make sure we have local experts who can tell us that, yes, the criteria you're using apply to the Kenyan context. And I also want to acknowledge Dr. Boniface Chitai, who's the head of the Kenya Psychiatric Association, who really helped with reviewing the tools and even training the data collectors to use them. So with that, I'll end. And I just want to thank the Ministry of Health and all partners for inviting us. And I'm really delighted to learn more about what we can do collectively to improve the lives of adolescents. As I mentioned, I'm a mother to two 16-year-old girls. That's a challenge in itself every day. Thanks.
Thank you very much for that wonderful presentation on mental issues. And of course, all of us are aware that mental issues is a big issue at the moment. So let's clap for her again. We'll move swiftly to welcome Omani. I know we have sometimes forgotten those with disability. So you'll say something small on that. Thank you. I can support you, or you can speak from there.
Good afternoon. Yeah, so as mentioned earlier, my name is Lawrence Omani from the Kenya Center for the Blind. I'll just be brief. I'm not talk a lot. I know this is in Masak. So nowadays you find people with laptops. Nowadays you can install WhatsApp. So when you start calling people, you might think somebody is looking at Excel, like you WhatsApp. So one of the groups that has been forgotten in this conversation, I think, is persons with disability. When I was an adolescent, even though today I've decided to become one, when I was an adolescent, one of the main challenges we had was lack of information. As a visually impaired person, you might require braille or soft copy materials. So if you are to give me this laptop here, without the proper software, it's basically useless. So even if it has the information I need, it won't happen. We are focused a lot on physical access, which is a good thing, obviously. Although I have somehow noted that this platform might not be accessible to everyone. But we have forgotten access to information. You see, when you put an advert on television or on a newspaper, definitely you do not expect a visually impaired person to be able to read it, especially newspapers, because newspapers don't talk. At least for the television, there might be somebody with a voiceover. When you make films, we forget to use audio description, which is basically whereby somebody describes the actions in the video. If you want to know how audio description works, if you have Netflix, you can always turn it on briefly just to see how it performs. And therefore, adolescents with disabilities lack the proper information. They are in schools, but they do not have anybody to talk to them. Or sometimes when people come to talk to them in schools, because we're used to presentations and everything, sometimes you might present something, but because the people cannot see those slides, they might not get all the information that they need. However, I'm pleased to say that the people who have been presenting here today have done perfectly well. They have mentioned all the figures, everything, which is actually really good because that is the kind of information that one might require. And persons with disabilities have capabilities just like any other person. Personally, I don't know whether I should campaign for myself here. Also to campaign, maybe dog. Personally, I have a degree in economics, believe it or not. So, and I'm the only one visually impaired person with that degree, at least in this country. And the reason I'm mentioning this is that anytime you look at a person with disability, you always see their capability before their disability. The person comes before the disability. You just need to give them reasonable accommodation, and that will be it. They might not require much, of course, depending on the disability. So therefore, my plea to you today, as I close, as we design programs, let us remember the PWDs. Let us not leave them behind. They are also adolescents. It's not just the able-bodied who are adolescents. So let us not leave them behind. And I think with that, because I know, because of time, I'll close there, and I think I've made my case. Thank you very much.
Thank you very much, Mani. Let's clap for him again. For that passionate appeal. Thank you very much. At least for this forum, it was important to get such kind of issues because I know in most of our programs, we rarely plan conclusively on those with disabilities. Yeah. So even for us, our division, we have a section that deals with rights and protection and those with disability. Thank you very much. Just a quick one from Dr. UNICEF. Yes, just a few comments. Thank you. Karibu sana.
Yeah, you baptized me, but Good afternoon, everybody. I'm not going to make a presentation. Personally, I was thinking today there was no presentation. I was shocked to see so many presentations. I thought there was a bit of kusikia the voices, the voices of adolescents. I was looking forward to hear a lot, and probably a question and answer session so that you can also hear their voices, what they're saying. As UNICEF, we are very passionate about that, and we look forward to having more of this forum with Dr. Juliet and team so that we can have those interactions, especially for programming. Now, allow me to just mention that I like what you talked about HPV. It's something we are also passionate about. And we hope we can also use these forums to have many adolescent voice. Yeah, they are concerned, educate their other people so that they can access this vaccine, which is free. At least for the girls, it's free. Yeah? I think for Kenya, it's just because of the budget. Otherwise, everybody, the boys and the girls should be able to access this budget. So I want to, we in UNICEF, we are in different sections. So allow me just to ask my colleagues to say 1, 2, 3 things. We have somebody from nutrition section, then we have somebody from communication, Jane, just to say a few words about their commitment so that you hear they are committed to this adolescent course. So I'm from health section, but I have my colleague from nutrition. Olivia, can you just say something on nutrition commitment? And then Jane, and then we close. This will be few words.
Okay, I think the chair is a bit concerned in terms of time, so I will not take much time to, I would say much. As Judith has highlighted, UNICEF is very committed to adolescent programming, so even on the nutrition front. I'm representing the nutrition section, and I would just like to say that we are also committed to support adolescent programming. There's lots of issues and challenges that have been highlighted, and including the presentation by Juliet, that really the first thing that was presented was on the nutrition issue. So we've taken note, and we continue to support programming for adolescent nutrition. Thank you.
Hi, good afternoon. Good afternoon again. Kwa majina naitwa Jane Kariuki, na kweli kama mwenzangu amesema nafanya kazi na shirika la UNICEF. My core business is social behavior change communication. Basically, what we do in social behavior change communication is not listening to this side of the room, but listening to this side of the room. These are the people who tell us what their issues are and what needs to be done and how it needs to be done and how we need to get there. So for me, on behalf of UNICEF and the SBC team, I want to pledge commitment to support the adolescents in this country realize their dreams. Thank you so much, and God bless you. And I think with those few remarks, Chair, we are finished, and just say UNICEF is committed to support this course. After WHO, our big sister has presented numbers. Now, as we say, the talking. So we're finished. Thank you.
Thank you very much for really being on time and also for the commitment. Actually, your commitment happened. We know very soon we shall be called upon. So thank you very much. All the talkings are over, all the presentations are over. So for the next session, it's just question and answer session. We'll open it to hear what the adolescents are saying, what we think should be done. So it is an open session. So going forward, my work is limited. I'll hand over to Jerry to take over the next session. Thank you very much.
Okay, I'll just jump down. Pray for me. I need it.
All right, so we are having question and answer, and I realize question and answer stands between us and lunch. So, as the youngins say, yeah. So I want to start on this side of the room. Tumeongea numbers mingi. There are so many graphs we've seen, so many things that we have said that's happening. Does anyone have a question or a challenge or just a statement? I love it. Please, pigia makofi. Just quickly state your name and your question or statement.
Okay, first, my name is Transformation from school. And the challenge we face is with adolescents is, let's say you have something going on with your changes and you're afraid to talk about it, so what should we do about it? For example, let's say maybe one of your parent asks you if you're feeling okay, and maybe let's say you're afraid to talk about it, and you're not afraid to talk about it because some friends will try and discriminate you. So what do you do?
What will you do? This is a good question. Who wants to answer? Let me tell you. The room has answers. Do you guys hear the question? The question is, what do I as an adolescent do when I'm experiencing changes and I'm feeling a bit embarrassed or having experienced some form of bullying or any form of stigma, and I'm not feeling comfortable being able to talk about it? What can I do? Who would like to attempt? I love it. Oh, thank you so much.
Hey, as hata mimi you're adolescent. So, as to kwetu, you just have to dial 1190, wanajibugi maswali zote hizo personal.
1190, 1190.
Yeah.
So dial 1190, they answer all the questions. I love it. There's another response.
As a parent to an adolescent, I believe charity begins at home. And there is no any other person that is so trustworthy or trusted to give you very, very good and fundamental response to the changes in your body than your parent. So start by talking to your parent or any other trusted adult. Many a times when we might want to consult our peers, and then we end up being duped. And our parents, there are several opportunities, but some that are known as the teachable moments, that you can seize, and you use that teachable moment to respond to the questions that are coming from your adolescent.
Thank you so much, Patrick. I have another question here.
Okay, so my name is Lorinda from Nairobi School. And so we know that adolescents suffer from several mental health problems, ADHD, anxiety, and stuff. And as an adolescent, you might feel that you can't talk to anyone about your problem. So who should you go to when you're having trouble with your mental health?
Who should you go to when you're having issues with your mental health? I'm pointing in the far direction as you answer the question. I know there's a psychiatrist in the room, that's what I'm pointing. Beyond.
So first of all, I want to say we normalize having mental health condition. It is okay not to be okay. And you know, even by being young people, adolescents, everyone goes through mental health issues. So first of all, acknowledging or affirming yourself, it is okay where you are, and it is okay for you to go through those mental health, stress-related issues or whatever mental health condition you feel you're going through, and it is okay for you to actually share it with somebody else. It doesn't mean by you sharing, it doesn't make you less of a person. It actually makes you human. So normalizing that conversation and affirming yourself that it is okay for you to share it out, that is, you are actually on the step to the right direction.
Thank you for that great question. Actually, who do I share with? Beg your pardon? Yes, the young people at the end. Can you hear me? Wave if you can. Okay, thank you. That's a great question. Who do I talk to? And to my mind, I'll answer it in two parts. The first one is ideally, yes, we should be able to talk to an older person. I think one of the parents has indicated that. We should be able to talk to some of our healthcare providers in some of the places that we operate within schools, for example. But I guess experience has shown that people are scared to talk to some of those people. So it does cause a bit of a challenge. I guess the hotline is also a good place to go, where you can have some of those questions answered. But we do also have some organizations and institutions which actually do provide for that facility. So one of the things that I've seen a lot of young people now start doing is that they tell their parent, they tell their teacher that, you know what, I think I have a problem and I'd like to discuss it. Can you take me somewhere? And the thing about it is, hopefully the parent can actually bring them into a place where they can actually get attention and then step out so that the young person can actually address their particular issues. So part of that, in other words, part of it is about the responsibilization of now the younger guys, adolescents, being able, as has just been emphasized, to start to normalize mental health issues, to be able to say, look, I think I have a problem, I'd like to talk to somebody. Okay, thank you.
I think I have a problem, I'd like to talk to somebody. All right, I'm going to come here to one of my former deskies of the day. Please ask a question.
It's actually not a question.
Yes, please go ahead.
It's a statement. Happy to be.
Your name, please, and
Yes.
what you do.
My name is Eunice Ndenya. I am a nutritionist, certified nutritionist. I am also a content creator. So on social media platforms, they call me Nutrition by Ndenya. And the statement I wanted to make to the adolescents in the room, most of the times, and I'm really happy that we're having this conversation, I deal a lot with your parents and your big sisters and your brothers. And one of the things I've realized is we are having a lot of issues with eating that do not start now, when we are in our 30s, our 40s. So to the young ones, I'm really, really hoping that when we go back home or to these platforms, that we can actually start talking about our eating as young as the adolescents, because that's when you're in a position to actually start understanding why. Dr. Juliet did a very good job when she was sharing about our sedentary lifestyle in the adolescents. It's actually really scary. So for us to reduce the burden of the NCDs, non-communicable diseases, I think it's very key to start talking about the eating in adolescents, so that now we don't have adults struggling to understand what to eat and when to eat, when they are struggling with work and looking for money. So thank you for this platform. Actually, absolutely loved it.
That's amazing, Benya. Thank you so much.
Hi everyone. For the records, Totos, this is a safe space. Sawa sawa. This is a safe space. No one is going to hurt you. Sawa sawa. Mtoto uko na uoga. And there's not something I normally do. I was to do it in the morning. I would want to see any parent who is a teen parent to a boy. Amka tu, simama. Good, simama. Who is a parent to a teen boy? One, and then you stand, mommy sit, daddy stand. Daddy come. Yes. Higher, a teen boy, anyone? It's a safe space, come. Happen to, yes. You come. Hi, how are you? Kindly give them the mic. Kindly. Give him the mic. Yes, I was to do this in the morning, but time was not on our side. Hi. Then from here we know what is the problem, who is the problem, and why is the problem. Sindio, kucha huko atakuko has. Consent, teacher, consent. Consent. Very consent, hapana. Assent. Are you okay? Any question? Assent. Consent. When you had your first wet, no, when you had your wet dream, who did you tell first?
My mother.
We didn't even
girlfriend? Child. Do you have a girlfriend? Imagine be honest. I am sorry. Have you ever crushed on a lady? On a girl? Who did you tell?
My mom.
Next question is very tricky, and you can choose to answer or to answer. So, are you a virgin?
No, not a virgin.
No, he's not a virgin. So, excuse me, it's a safe? It's a safe? Until you are free to have this conversation, something is wrong somewhere. So, you're not a virgin, so you're about sex, serious? No. Are you a virgin? Oh, he's a virgin. I'm not for him. Daddy, Mambo, you have a teen boy, age? 17. From 4. Yeah, you must be very handsome. That is my answer.
Thank you.
Can you remember the day he had this? Are you close to your son? I know you can lie, but it's fine. Sawa. So I wish he was here. Do you know his girlfriend? But you know he has a girlfriend.
I'm not sure. Has never disclosed to
When he had his first wet dream, are you aware? Are you aware that he has ever wet dream? You're not aware. And who is the parent? Who is the parent? Him. That means there is a gap. You can see. Now, there is a gap. We are leaving all these things for LVCT. We are leaving all these things to Tika, to USAID, to Gen Trust. Which one? 1190. Yeah, in Amsterdam, and the baby is yours. And you are part of the. You two sat down together, decided we don't want to have a baby. Single. But 17 years down the line, not even aware if he has a girlfriend. If he has ever wet dreamed. Are you feeling the gist? Yes. Is there a problem? The problem is not these kids. It is not. The problem is not them. You see this conversation here, but to have them and their parents. Trust me, most of their parents don't want me. Because I go to forums and do this, so because the guilt you guys have. This thing to be funny with the girls and a mother. And then the cycle continues. These girls are having information from Google, from ChatGPT, there's one I saw HPV Mutu Hazai. Who told you that? Who told you that? I'm not sorry. It's a safe space. You can quote me anywhere. When I start to speak to children and to young adults and to teens, it's not controversial as normal. We don't laugh. They air out their views. Parents sit and air out theirs. We rant and they give. Asante.
Thank you so much. I wasn't sure where that was going, but I absolutely loved it. Loved it. I'm going to try it in the next forum. Pray for me. Today, intercede. Now, I have a question that I always ask people. How do you want to be addressed? Do you want to be addressed as a teen, as a child, as a young person? Which one do you feel? Because I know we have called you today children, we have called you today Toto, we have called you today teen, we call you today young people. Sample, yes. So, how do you want us to start to address you? Think about it as I'm getting another question. Sawa? Okay. Hands. Okay. I'm kind of off flat shoes.
Hi. My name is Maureen Kinge. I'm a pediatrician. I like to think of myself as a young person, but my knees will beg to disagree. So I am not a parent of an adolescent, but as a pediatrician, one of my main roles is to be an advocate for young people and for children.
So I do not consider myself a voice to those children, but an amplifier to their voices and a translator to the people who may not understand where those voices come from or what they mean. So with that said, I wanted to make a comment, and I'm very glad that the conversation that has gone on. And she's very rightly highlighted that we do have a very big gap. The questions that they asked in the beginning are representative of what is happening with a lot of young people. They have questions, they have concerns, but they don't have a safe space to air them. And the reason why there's no safe space is because they are in a place where there's no ownership of this population. So when you talk to the pediatricians, many will say, I don't see people till they're 12 years. When you talk to the physicians, they will say, me, I see people who are 18 years. So who is it, the person who is between 12 and 18 years, they have no space. There are people, any person who identifies caring for children often talks about people who are under 5, children who are school going, in primary school, but this is a very neglected population. And one of the key challenges that happens when we're having the parents, the stakeholders, and these other people on this other side is we do not understand the reason why they are having these challenges. And I just wanted to give you 1 or 2 examples that just try to explain why they are asking these questions and why the behaviors that have been highlighted up there are actually happening. So when you think about, for example, why are these children getting pregnant? Why are they taking drugs? Is it because we are raising them inappropriately? Is it because we're doing a bad job as parents? She says maybe.
It's a tough question.
The parents are adamant, no! We never want to be wrong. But we fail to recognize that developmentally, and this always cuts across, whether you're dealing with terrible tooth or you're dealing with an adolescent, whenever you're having conflict between a caregiver and a child, it is often because you do not understand the changes that are going on in this person. So the stage in which they are in their brains, do you know at what point they start to be able to control their impulsive behaviors?
I'm trying not
When
to
are they able to control their impulsive behaviors? Yeah? In their 20s. So innately, anyone who is their age in high school, their brain is driven towards risk-taking behavior because their reward system is when they take a risk and nothing happens. And they have this sense of immortality. You tell them they will get pregnant. Who gets pregnant? Only people, other people out there. I can't get pregnant. I can get hooked on drugs. No, I only take it once, twice. My mom takes alcohol. She's not an alcoholic. So they have this sense of immortality and they will feel that they are okay. And there's a reason why that brain was created that way. Because at 21, you will expect this child to move out of your house. So how will they move out if their brain has not been created in a way that they're able to do things that push you away? So once you understand how these changes come about and why they behave the way they do, you will then stop looking at them as the small babies that you had when they were still calling you mom, and start to see them as the adolescents who start to push you away and now need another safe space and you to look at them differently and accept when once in a while they call you Mokoro. Because you are now different to them and they are now have a different sense of independence that is very different from you. So my plea to my colleague up there, I hope that in this program we have parenting classes for adolescents, because that is one of the biggest things that we need to bridge, because many of us are not equipped to handle that age, and that is the reason why we have this issue.
Thank you so much, Maureen. All right, now let me ask a question. In terms of adolescents, how does the law protect them? When we talk about health, well-being, how does the law protect our adolescents?
I decided to ask a lawyer.
Hi everyone. I mentioned the introduction that today is my birthday, but since I'll have to generally, the legal scope in Kenya is quite protective of minors. I don't use the term adolescents because there's a bit of gap. You know, the law describes a child as anybody between 0 to 18. And from what I learned today, an adolescent it stretches till 19. So then there's a bit of a gap between at what point do you stop acting like a child and you realize then that the protection accorded under the law ceases to extend to you. So then you become an adult. So what I'm going to say extends to children, that is till 18, which I believe our sample today belongs within that category. So I'll start and Julie mentioned, I think that is pillar 3 of the new policy that is yet to be out. That is to promote a positive legal and policy environment for adolescent health. Yes. So I'll start with that. You know, laws come from policy. Policy informs the laws that we make, and those laws are debated in parliament. Finally, they are passed, and once they're passed, you have to adhere to them. So, based on what I had today, I'll give 3 ways in which the law protects children and by extension adolescents. One is I'll be giving the sexual and reproductive health. So how many are parents to teenage boys? Yeah. One was next to me, but he seemed to have yes, and to all the male adolescents in the house, the law is quite protective, but very harsh on teenage boys. Yes, so to those of you that were raising your hands, that you are no longer virgins, and the safe space of that was given up there. This is just a caution that the law is not very kind to teenage boys, especially who engage in sexual activity with teenage girls. So that if you're 17 and you engage with a girl who's 17, you'll be convicted and the girl will go. So if you want, you may try it with someone who's 18 and above. But as regards what the law says, anything below 18, if you try that with your peers, then that is not very much taken kind. Your parent won't be able to protect you, your teachers won't be able to protect you, your school won't be able to protect you. Neither would I be able, well, they can to some extent, but the law is not very kind on boys who engage in sexual activity with girls below 18. Other countries are, you know, if you look at it, it's quite unfair because those are 2 people who are both below 18, but now our Sexual Offences Act is more discriminating, so it should penalize the guy. Some countries, like some states in the US, have things we call Romeo and Juliet laws, from the story of Romeo and Juliet who were underage and because. So these laws allow them to permit young boys who engage in sexual intercourse with a lady who is 3 years, a gap of 3 years, his age, then they are allowed to go. But Kenya is quite restrictive, yes. I think South Africa also adopted that leeway, but for Kenya, the parents are a bit strict on that. So if you are a teenage boy, don't try. You might try with someone who's above 18, but for below 18, don't try it at all. And then for cyber harassment, there's the Cyber Harassment Act that gives teenagers that protection. And then lastly, for FGM, I had that being mentioned. There's the Anti-FGM Act. I think that it's also quite strict. Penalizes and if FGM is done in your house, you'll also go in prison with the person who did it. If you aid and abet FGM, you'll also go with the person who did. If you do FGM, the sentence is life imprisonment. So the law is quite protective of children.
Thank you so much. Thank you. I have father of a young man. I didn't get your name. I'm so sorry. Now I'm using descriptive language.
Okay, thank you so much.
And let's keep our statements or questions quite short and our responses quite short so that we can get as much as possible within the limited time that we have. Remember, I am standing between you and lunch.
Okay, thank you so much. I'll be very short. I've not stood here to defend the parents, but I've stood here to say that we are parents who are in the transition period. Our parents were, kids are meant to be seen and not to be heard, to a point whereby our kids now are partners in our decision making in the house. We are discussing together with them. Like I remember the first time I had a girlfriend, I was in class 8, and this is the girl who transformed my academic prowess, which was always number 1. And then I remember we used to share, remember those days, most of us, I did my KSP many years ago, and I used to have papers from all over, was in Issue, Transoia, Nyandarua, all over. And then my mother was a teacher, so she would get papers from all over and create a file, a big file for all those revision papers, and she could even get the answers from other teachers. So one day, I shared this file with this girl called Eunice. She went to it at home, and when my mom asked where the file is, I told her, my mom had a bit of, this is a girl, my girlfriend, but I didn't tell her, but she had a bit of it like my girlfriend. I remember that night, she brought me to her home and picked the file at 9 p.m. at night. Because according to my mom, I was getting lost. Why are you having a girlfriend at class 8? I remember this was she was choppy by the way, and she made me become number 2. She became number 1 KCP. Yes. And the reason I'm starting here is because we have no forums whereby parents are educated, for example, on how to communicate to especially for the boy. My daughter is 13. My daughter is very open with me. Anytime I pick her from school, she tell me about a boy who harassed her. Like on Friday, she told me she's done with the boys. She told me boys are not focused. Boys, if you're a boy here, please cross your ears. Boys are moving from one girl to another. They have about 5 girls, and they are not consistent. So she told me, I'm done with boys. I don't have a boyfriend anymore. But my son is very, very close. Very, very. He keeps to himself. But then, as a parent, and this goes to the ministry, the Dash division. I'm part of your ministry also because we work together. How do we come up with programs for parents so that we can empower the parents on how to communicate, especially to the boys? Because the boys at the age of 13, and I just tell you one now, after circumcision, because for those who circumcise their boys, I'm sorry, because if you don't ask me to, after circumcision, the boys feel like, I can handle it by myself. Or the peers take over after that. So how do we handle that? So we need to educate it. And finally, please, organizer, this is outside this particular forum. All of us knows about the Data Protection Act. We have children in this house. As you take the photos, if you want to share those photos, please take care. I can share the handbook for data protection. I have it. We were sent last week. Handbook for Data Protection Act for individuals, so that you know, even for the media, even for the government. If you want to share any photo, even for me, I'm studying there. If you want to share my photo, have consent. Otherwise, if you don't have my consent, I can go to court and you can pay me. Thank you.
Thank you so much. The room went silent. Okay. But thank you so much. Very key. Please, if you could stand up, just briefly introduce yourself again.
So thank you very much and good afternoon, everyone. My name is Jean Kamau. I come from UNESCO. Just to appreciate also the presenters for the statistics that they've provided that always make us now realize that what we are doing, we need to do more. I just want to say that even as programmers, we need to look at the adolescents and remember they are not heterogeneous group. They are very, very, we need to map up and say, for instance, if they are facing challenges, if we are talking of a line where one can call, what about that adolescent who cannot be able to call, who doesn't have a phone, whose parents have not been empowered? And we need to look, even when we are talking of mental health, does it mean even when we are looking at this, are we having mental health issues in the community, in the society? which are actually now ending up exposing or even making these young people are vulnerable. And something else that we need to look and think of is the school-related gender-based violence. I'm sure everyone, it's always disheartening. I think about 2 or 3 weeks ago, a girl was killed in a pool, and this is happening too often. How do we ensure that these girls, these adolescent boys, these children, when they go to school, they are actually safe? And that is now calling upon the Ministry of Health. How do we expand even what we piloted together? WHO, UNESCO worked closely with the Ministry of Health and Ministry of Education in piloting the HPS. How do we expand this to ensure that our young children are safe in whatever they do? Because I think either we are becoming a society that doesn't care, a society that doesn't care. This is not my person, but I think we could do something and ensure that we benefit these young people, even including what we are saying. How do we empower our parents that they can be able to speak out? Right now, I know the UN agencies are working with the religious leaders on what is called the triple threat to ensure that they empower the parents to even to open that door. Even the parents who are here, if you ask them whether they are able to discuss openly, my kids are now, they are not, they are 20s. But even me, when now it comes to that area, as much as I'm working in this one, you find that now, first you don't want to believe your child is sexually active. There are many things. We wear that role of a parent. But how can we empower each and every parent to be open, to know that even when you take a child, I saw the discussions on the data on the alcohol and substance abuse. Since COVID, parents have moved the bars to their fridges. So this child is opening the fridge, can see his juice, can see the mummies, whatever, wine, and of course there is a spirit for them. So we have actually turned upside down, and so these are some of the things we need to have very honest conversation as a country. Thank you.
Thank you so much. Now, there was quite a bit of information that was shared with us, and I want us to start thinking about what is one practical, actionable thing. What is one practical, actionable thing that you will do to help a teenager in terms of their health and well-being? One practical, actionable thing. You could be talking as a parent, you could be talking on behalf of your organization, it could be the students who are here, the teens who are here. So let's think about that, and I'll ask Vivian to speak briefly.
Hi everyone. My name is Vivian. I'm with Gertrude's Children's Hospital, and I wanted to answer the gentleman's question, the father of the boy, and the other lady who asked a question on what do organizations do to empower the parents. As a hospital, we do what we call health talks, and this is where we engage schools, churches. When the parents are gathered together, we can give them, we can educate them on a topic of their choice. Maybe the school sees that there's a gap in this area. Can you come and talk to the children about, I don't know, menstrual hygiene, which is something that actually our very able Dr. Jerry does. She's our pediatric adolescent specialist. So that is one of the things that we as a hospital do for the parents of the school. So if your child goes to a specific school, you're welcome to reach out to us to ask whether, oh, can you come and do a topic on a specific topic, any topic. If you feel like, come and talk to the dads of the school, we can come and do that. All right? Because we want to educate you, we want to give you that information to be able to take care of your kids, to be able to give them the information, or to be able to even have a relationship with your children. And we also have our psychosocial department that does that as well. So, thank you.
Thanks, Vivian. You know, when a teacher puts up her hand, I rarely see a teacher putting up their hand. Usually it's us putting up our hand for the teacher. So please, Walimu,
thank you.
What do you think about all this?
All this is happening, and I think, as you said, we need to look for a practical solution. I would like to echo her presentation. Look at this scenario. Let's agree, in Nairobi, most of us are mechanical parents. Our work is to provide. We go for seminars, we go for late night dates, we are out here looking for money. So the question comes in the morning, have I paid your school fees? Are you missing anything? Now go to school. When this boy comes to school or this girl comes to school,
mimi kama mwalimu I'm busy, nataka nimalize syllabus. Nisigombezwe na head teacher. So we still we have that glaring gap. And I think in our school we are coming up with a health club, and I think maybe the government and the organizations that are concerned, please come and farm up our health clubs, whereby we believe as teachers that peer-to-peer teaching is very, very important. She may be going through something that she went through. She can give her a practical solution. In fact, they listen to each other more than they listen to us adults. So if maybe you could come up with health clubs in each and every school and monitor those activities, maybe you could have a better teenagers. I absolutely love how practical that suggestion is. And I also liked how Ariana had also shared that she's a mental health ambassador and they do a lot of peer-to-peer. So maybe you guys can talk to her and find out how they've managed to do that in the school, because that is a sort of like a support system that she spearheaded and they have been able to support. Suddenly this side of the room went shwa. Oh my, can I start in order of age? 10 to 19? 20 to 29? Can I start there, then I'll come? Can I start there, then I'll come?
Wow. Hi. Well, let me just stand.
Okay, for reference, she didn't tell me her age. I just decided to start at the end of the room. Bear in mind, these guys on this side of the room, when you are mikono, I stand between you and? Okay, so, maneno mafupi.
So thank you. My name is Swing Okeo. I come from Women in Justice Centers, and I also convene young mothers in Makongeni. So mine is just to emphasize on parenting. Surprisingly, or good enough for me, I'm a mother of a teenage boy, 15 years. Yes, you may be shocked, but that is the truth. I got pregnant at the age of 17. Not because nilikuwa na tabia mbaya, hapana. Because I lacked that information. So this is to our young girls and boys here. The rapport that you make with your parents, like when you come to your mom, you want to discuss something with your mom, and your mom is like, Daddy, I'm tired, so let's talk about this tomorrow. If I had that chance to talk to my mom that kuna venye na feel ama kuna venye someone is after me or something,